Hey everybody, my name is Mario Martinez and this is Amateur EMS. So today I thought it'd be a lot of fun to do a tier list. I love running through tier lists, but I noticed there's not any on like medical scenarios. So I wanted to do this on the perspective of a paramedic such as myself. I haven't been in EMS for too long, just about like 4.5 years or so. I'm almost at 5 years. I'm an EMS instructor. I used to work at a clinic for probably about 8 years. So I'm okay at medicine, but by no means am I an expert or anything. While I may have had a couple of these scenarios before in the past, you may have had a horrific one, and something that's easy for me have been extremely hard for you. Each patient case is going to be different, but I'm just going to kind of weigh in on my opinion. If you disagree, leave a comment. I'm cool and open to any other interpretation. So what I have here is I can do this in my sleep. These medical emergencies have so far been extremely easy for me. A little tricky, time to lock in if if it's a really bad one. Call for help because I'm in trouble. Like this is a very tricky scenario, and I've never done this before. So with that said, I have AFib RBR, and I think it's a little tricky. I've been lucky enough to work at an agency where they actually had cardizem. At my current one, they don't though. And I've had a patient with RVR for AFib, which just means basically an accelerated AFib. They had an altered mental status, their vital signs were a little out of it, and they were pretty symptomatic. I gave them cardizem. I think the two doses is 0.35 milligram per kilogram and then 0.25 milligram per kilogram. I think it's that way. It could be reversed, but it's been a while since I've had it in my med list. Um, and it worked. It converted them. Luckily, I didn't have to synchronize cardiovert. If I had to synchronize cardiovert, it'd definitely be around here. But it was an easy call for me. And I think in the future, once you experience it the first time, the next time is so much easier. So I'm not too worried about it personally. Appendicitis, I can do it in my sleep, but let me tell you, if I suspect that you have appendicitis, you're going to the hospital. I'm going to do everything in my absolute power to convince you to go to the hospital. I'm going to take it extremely serious. I had a family member who had appendicitis, and that was very stressful, but luckily we got it in time. And I don't mess around with this. If you have right lower quadrant abdominal pain, you need to go to the hospital. Okay. Alcohol emergencies, they're extremely easy. A lot of times, these people really just need to eat some fast food, drink some water, and then go to bed. But of course, I'm going to treat it accordingly. If I think that they need to go to the hospital, if they appear that way, I'm going to urgently convince them to go to the hospital. I'll set up an IV on them, give them some saline that usually can help wake them up. But for these patients, they just need some food to digest usually. But of course, they're going to be a little bit more aggressive. You can call PD for this. But, as long as you treat people with respect, usually they're pretty easygoing. Asthma attacks, extremely easy. Setting up albuterol is a lot of fun. Generally, for an adult patient, you're thinking like 5 milligram per 6 mLs of albuterol, so that's usually two doses. In a nebulizer at 6 to 8 liters per minute, that's really easy. And then we can consider some other drugs if necessary. But besides that, some agencies have a mix where they do like 2.5 milligrams per 3 ml of albuterol and then 0.5 milligrams per 3 mLs of Atrovent, and they'll usually do like a combination. That's fine. However, you have to set it up. Even for pediatric kids, they usually patients who have asthma, they're used to taking nebulizer treatments, so it's nothing new for them. Bee stings, ooh, I'm actually gonna say it's time to lock in. Okay, bee stings, they seem like they're easy, but if you have a patient laying out in the middle of a field and they've been stung 30 plus times, their fluid is starting to permeate the vascular tissue. They're going like semi-conscious. They're having trouble breathing. It's time to lock in. It's time to point at your rookie that's with you and say, hey, I know you haven't been on many calls. I need you to bunk out in our bunker gear, and I need you to grab that patient and pull him out. We actually have bee suits on our brush truck at my current agency I'm at, or current department, and we can suit up and go help a patient there. I don't want to get stung. At the same time, you don't want to pull out the stingers with like a tweezer or anything. You want to use a credit card to kind of help pop out those stingers, because if you use a tweezer, you can push the venom in further. So be very careful with that. I don't want to get stung. Even in fires, this is a huge pain to deal with because I don't want to get stung. Burn patients, they're honestly, it's extremely sad, and I haven't had like a horrible third degree burn. Okay, so I'm biased. With that being said, the patient's usually in a ton of pain. You know, we think about giving them fluids. We think about like cooling the area, but then you want to put like a dry, sterile gauze over the area. You don't want to put a moist one because if you do and then you bandage it up, it could potentially still be a hot area. So then you create steam. It burns the patient even more. Knowing your degrees of burns, knowing your rules of nine, the rule of palms are all great ways to help differentiate what's really how much surface area is burned. We don't have a burn area center that's close by, so then you have to kind of think, do I need to fly this person out? Should I advise a hospital early so that they can set up Halo or some other type of flight company to send them off to the nearest burn center? It's really up to you. But generally, our burn patients aren't usually that tricky, but when they're tricky, they're tricky. Chemical exposures, I've never experienced this before, but my teacher had a great saying where if you come into contact with what you think is like a, let's say like a company that produces like cyanide or something, and you smell like almonds, just take 3 deep breaths because you're going to die regardless. But I've never had to experience this, nor do I want to. But I do know if there's like a powdery chemical, you can try to brush off the chemical before you apply saline to it because you want to try to get off as much as you can because we don't know if those chemicals are going to react with saline. So be very careful with that. We also have calcium gluconate, which we can give. It's like a topical. I think it's for hydrosulfuric acid burns. Don't quote me on it though. I have to look up back on my protocols. But I don't want to deal with this if possible. Chest pain, easy. Chest pain patients, we give them aspirin right away. We set up a 12 lead on the patients. We consider nitro, but if you're going to do that, you want to set up IV with some saline being administered, or at least have it ready just in case they end up losing too much blood volume too quickly, or if they go from like normal vital signs to overly hypotensive, you might end up killing someone with nitro. Same with morphine. It's an option. You can think of the acronym MONA, which is morphine, oxygen, nitroglycerin, and aspirin. But these are really easy calls. Of course, if they're having a full-blown heart attack, it can get right around here real quick. I might need a tailboard. But I would get so many of these, you kind of just know what to do. Choking, you got to lock in. You have to lock the F in because either you're going to be a hero or this person's going to die. I remember one time I've had a patient before where they were, I won't specify too much into it, just for like HIPAA reasons, or I won't say when, but they were choking and it was like during like a family like get together and I showed up on scene and they're all like sitting around at a table and this person's just choking and like laying down on the floor just like choking and I was just so astonished. We ended up saving the person, which is great, but you have to think of a lot of things, right? You have to think first, you're going to do back blows mixed with chest thrust. Mix around with that, you're doing like a Heimlich maneuver, then they lay on the floor. Okay, you should already have your partner, if like you're doing like your third round and you're like, this is not coming out. Okay, I need you to pull out the Magil forceps. I need you to pull out an ET tube. Like if you have multiple people, you pull out the ET tube 7. Let's get to work. I don't have surgical crike as one of my options at my department, but these are things that I want to think of. I need to think of maybe like, hey, you over there get the stretcher ready. We might need to go to the nearest facility where they can potentially do a surgical crike. We have one that's like maybe like 5 or so minutes away, or 10 minutes depending on where we're going to. All these things need to be running through your head. So if you can't get it out with back blows or chest thrust, then what we need to consider doing is we need to maybe use a Magil forceps to try to pull it out. You can consider the blind finger sweep, but if it's not a baby, I'm not really going to be doing that because I don't want them to bite my finger off. Tell a family member to get a towel also because you might need to block the opening for the finger sweep if you're going to do that. You can put that like on the side of their mouth. And then at the same time, last resort, get an ET tube, shove it down their throat as they're falling unconscious, and try to push the obstruction into one side of the lung. So it'll go into the right stem usually because that's the bigger opening. And then you'll be able to oxygenate with one side of the lung. It's not ideal. I've only had good experiences with this where you basically seem like you're a hero, but it could very easily be dog water if you're stuck with this. CPAP calls, honestly, they're kind of on the high end of a little tricky and time to lock in. For respiratory distress patients, a lot of people will be very quick to apply an airway device, but we usually bring our monitor out at the same time. I've had it before where I've actually, whenever I was a student and I worked with really talented medics, they were both also nurses, that they're both RNs, paramedics on the medic unit. So it was great to see them in action. And while they were setting up an airway device, they put the pulse ox on the patient and they got a room SpO2. I think the patient was setting at like 60%. They're like, I can't breathe. Give me oxygen. Give me oxygen. They're like, look, we need this. So use this. We're not withholding oxygen, but while we're setting up, let's get a room SpO2. And if you don't, the nurses are just going to yank off your airway device and they're going to set up the pulse ox on them. So it's better just to get one anyway. These are pretty easy. All right, these are pretty difficult. But if you're competent, if your crew's competent, you can set this up. Most people don't know that usually like PEEP devices will actually have the O2 administration regarding the PEEP level. Like 5 PEEP is usually 8 liters per minute, 10 is at 12, and then 15 to 15 all the way up to 25 to 25. But training is generally needed for this kind of equipment. I have this for basically like a dead on scene. Like let's say they're already presenting with rigor mortis or something, or obvious signs of like prolonged death to the point where we wouldn't consider CPR. We would more so just print out our 2 assistally leads and wait for our call PD if they're on scene. They'll usually wait for a medical examiner, which they can examine the body and see what happened. These are extremely easy calls. However, you do have to be very kind. I would even put it like right over here if this is the easiest. Maybe right here. You have to be a support column or a support structure for the family member. You have to look at the family member and you have to be very kind to them. Usually it's like what happens is they leave their parents' house at like 10 p.m. They come back at 6, 8 a.m. to go check on them. Oh my gosh, they're dead. They've been dead for probably like 4 or 6 hours. It's nobody's fault. Or they both went to bed in the same house and you wake up they wake up, notice that their family member's been dead for X amount of hours, like their wife, their husband. You show up on scene before you start CPR as a medic. You should look like, hey, try to move their jaw. Can't move it. Hey, look for pooling. Oh man, I see it. Oh, their arms are so stiff. All these things are happening. I think that this patient has been dead for too long. We might need to call it here. Let's go ahead and throw the pads on a patient. Be very careful about on the field, I think it's called pronouncement. But make sure, like if you have any of your coworkers that show up on scene, like let's say you have a brush truck showing up too, if any of them think you should work it, err on the safe side, just work the call. If a family member wants you to work it too, and you talk to them and they're like, hey, no, I just want you to, okay. It's good training at the very least, but treat them with respect. DNRs? Oh, these are extremely tricky. I'm going to put them as time to lock in. Because if you show up to a patient that's dead and the family member's like, wait, I have a DNR, you need to point at them. And not in an ugly way, but you need to be like, you need to show me that DNR right now. And they've got 5 seconds. If they're struggling to look for it, I'm going to look at my partner, start CPR. I don't care that they have a DNR, supposedly, allegedly, because unless you can present it to me immediately, and I mean immediately like 5 seconds, I'm starting CPR. And I will stop as soon as you can show me a fully filled out, properly signed, formed, like the proper form and everything. Until you can show me that, this means nothing to me. But do not be one of the medical providers where you go up to somebody's family and they say, oh, they have a DNR, they have a DNR. And if they don't present it, it doesn't matter. I've had it before where we started CPR on someone. They said they had a DNR. I was like, okay, well, show me it because we're still going to do CPR. I did my algorithm. I was like, a 1 minute in and they showed me a fully signed DNR. Okay, good job. I thanked the family member. I was like, thank you so much for having this readily available. That's extremely responsible of you. And now we're able to respect their wishes. And I praised the patient, and you should always praise the patient if they do this. Now, if they do not have I've had it one time where I've done CPR on a patient. They said they had the DNR. I told my captain, hey, go in there and go check for the paperwork. I'm going to make sure this code runs right. 8 minutes later, oh, it turns out they didn't have the right form. They didn't have a DNR filled out. It was something else. While I was doing CPR properly the whole time, I'm glad I didn't listen to them. So be very careful with this. Pit bulls, or I'm going to say dog bites, but really pit bulls. I hate pit bulls. I'm gonna say they're going right into a little tricky. I hate pit bulls. I understand it's generally dependent on the person who owns the dog or who is a family member with the dog, depending on how you see dogs. Um, I hate pit bulls. The only time I see people get really messed up is from pit bulls, and these are technically just dog bites, except for one time I saw a pack of dogs really mess up someone. But these things will rip you. They'll show you'll have adipose tissue exposed. These things, I don't think that they should be put down. But breeding, I think we should really consider slowing down breeding on these dogs. That's all I'll say. Drowning patients, these are extremely difficult. I don't know if I would say time to lock in. I wouldn't really. This column right here is kind of hard to put in, but as far as for like drowning patients, I'm gonna lock in. I've luckily had a drowning patient where I was like a kid, where we ended up reviving the patient. It was very sad. I can't really go into detail about it, but basically, you want to dry the patient. You want to stimulate them if possible. If they're going into cardiac arrest, work the code, of course. But there's like near drowning where they're in the water for a little bit, and then there's actual drowning where they like stop having a pulse. These can be very difficult calls. They're always going to be very difficult. And even if you pull them out of the water, you save them, they're like, I don't want to go to the hospital, they can still potentially go back into like cardiac arrest. So you want to always take these patients to the hospital. Just tell them like, it's just for peace of mind. If anything, you really have to be a good provider and say, no, you need to go to the hospital. This isn't really up for debate. I mean, I can't kidnap you, but I can damn well do my best to show you all the reasons why you need to go to the hospital. But I've had a good call where we ended up saving somebody who had a drowning event. But I'm sure this can be a very easy traumatic event for you. I'm going to screenshot it right here. Okay, this next one, excited delirium. Ooh, this can go a lot of different ways, or like a psychiatric episode. So if you perceive this as a psychiatric episode, then this is going to be something that uh, it's a tricky call, but you just need to sit down and really talk to the patient at first, then try to get them the help that they need. Some patients just need talking to. Some patients they really need to go to a psychiatric area, and like you need to be there for them. I've had one guy where he just wanted to beat up everybody, and I talked to him really calm. I was like, "Hey, would you like a medication that'll help you calm down? I have a sedative." And they're like, "Yes, I would like that." And I was like, "Okay, I would like that too because I think you can kick my ass." So gave him a sedative. It was an easy ride. You do have physical restraints, which I think are overhyped up in like textbooks. Of course, like there's a lot of like red tape you have to go through to set up physical restraints on a patient. Be very selective with it. But man, if you decide to put a physical restraint on somebody, make sure you put one arm above their head, one arm on the side of them so they can't generate force. And be ready because this can piss off a patient. I've had a patient before where I put physical, or I didn't put them, PD put physical restraints on them as I transported them from a hospital to another hospital. The patient was physically restrained with like restraints on the sides of the stretcher. I remember like 10, 12 people at the hospital had to like hold the patient down as they gave him like Ativan. And this patient was pissed. And luckily they calmed down a little bit. That person sat up on the stretcher, even though they're on Ativan, even though they had physical restraints, started tugging at their physical restraints and looked right at me. And I said, "Patient, would you like me to loosen those restraints a bit?" And they're like, "Oh, yeah." And I was like, "Okay." And I loosened it a little bit, and then we were calm the rest of the way. Why did I loosen it? Because I knew they were about to break out of it. And if I didn't seem like a good guy, it was just me and that person in the back of the box, they would have killed me. And that worked. But these can be a little tricky. You have to be a people's person. Do not make. I've seen it once where a medical professional, I put these in quotes, was like making fun of a psychiatric patient that I needed to transport, and I told him like, "Hey, cut it out. Stop talking to the patient." And I dealt with it accordingly afterwards. I won't say how I did it, but just do not provoke these patients. That's the last thing you want to do. What's really funny for this next one, for eye injuries, for myself, they're pretty easy. I understand more so how to deal with these kind of calls. Like if you bandage one eye, let's say if they have like an injury and you need to stabilize it, just bandage the other eye, because if they look to the left with one eye, they're going to look to the left with the other eye, and that's going to potentially dislodge an area. Um, if you want to throw off medics, just tell them I got some metal in my eye, just like a tiny piece. What should I do? And they're gonna freak out. A lot of times, just like an eye wash station or like imitating it is the way to go. Put them underneath the sink. Put them underneath the shower head. Let that run for 5+ minutes. They should be fine. Of course, like take them to the hospital. Let the professionals take a look at it. But generally, that's just easy, like an easy call to do. I would just say a little tricky, just because the bandaging can be kind of tricky, or sometimes you just can't flesh out that object, and they really do need to go to the hospital. Regardless, uh, fractures, I can do that in my sleep. Some people are so quick to they'll see like any type of obvious injury, like some abrasions, or they'll see some potentially like broken areas, and they'll be like, I need to spend 10-15 minutes splinting, or I need to spend 10-15 minutes like wrapping up all these scary looking injuries. It's like, really, they just need to go to the hospital. Check pulse motor sensation if you want to splint the area, if you're concerned about it. But if you do splint it, make sure you check pulse motor sensation afterwards. Don't get an IV on the affected area, get it on the other area, and you should be fine. Now, heart blocks. I feel fairly competent in heart blocks, but this is definitely a lock in moment. This is definitely a moment where I'm like, okay, I need to know what to do. I need to know whether I can push atropine, or if I have to go to pacing. And I've never had to do pacing before. But first degree heart blocks, second degree type 1, these are very difficult. Second degree type 2, third degree heart blocks, we need to move over to pacing. But I feel fairly competent in it, but you just need to lock in, basically. Of course, if they're symptomatic, even if they have a first degree heart block or a second degree type 1, then move over to pacing. For us, it's 80 on 80. And then you start to move up till you get electrical and mechanical capture. If you're a medic, you should know what I'm talking about. High blood sugar patients, I sleep. Super easy. These calls are very easy to do. You want to set up an IV. You want to give them some saline. Ask if they took their insulin. Gather some information from a bystander, because they're probably going through DKA or diabetic ketoacidosis. They're probably exhaling a lot of sugar. You can measure like their ETCO2 if you want. But giving them some saline will kind of help flush some of the sugar back into the urinary system, where the body normally urinates the excess sugar. So that can help. But getting them to the hospital is what they need. We don't carry insulin on our medic unit. Normally, ambulances don't carry insulin, as far as I know. So they need to go to the hospital. Heat stroke, heat exhaustion, I sleep. Actually, I'll put it on the top, the very beginning of a little tricky, kind of like in between these two. Just because heat exhaustion, it's pretty easy. They're still sweating, and getting an IV isn't too bad. Heat stroke is very dangerous, where the body stops sweating and you need to set up a IV. The tricky thing is, Sometimes you just can't get an IV on these guys because they're suffering from hypovolemia. So their veins are really just deflated. I mean, at some point, if they're really symptomatic, if they're hypotensive, you might just need to set up an IO or an intraosseous uh, port, where basically you drill into somebody's bone and set up some saline that way. And I think I've done it on a heat stroke patient before because I was like, look, like they're symptomatic, they're going unconscious, like I need to do this to them. And whenever I push some saline into them, they scream bloody murder. I gave them some lidocaine to try to numb up the area, did not work. But I looked at them and I was like, look, if you fall unconscious again, I'm going to have to give you more saline because you're too symptomatic. And they're like, no, no, no. And then finally, I got a vital or blood pressure afterwards. But these can be a little tricky. Low blood sugar, I put it on a little tricky. I only say that because getting an IV on these patients can be a little annoying. I mean, you should know what to do for these kind of patients for hypoglycemia. If you're an EMT basic, you can consider oral glucose. Make sure they don't have an altered mental status. Make sure they can protect their own airway. If they are not ANO times 4, anything less, do not give them oral glucose. You will kill them. Request ALS intercept. For paramedics, we can consider dextrose, we can consider glucagon if we can't set up dextrose properly, if we can't get a line. But just be wary. They're going to move a lot whenever you try to set up an IV. They're going to try to pull it out. They might try to punch you. It just depends on the patient. But if you have like an engine company with you, you should be fine, or like a brush truck with you. What I mean by that is if you have like 3 or more personnel. For these patients, if they have low blood sugar but they're ANO times 4, if they're talking to you, if the family members there, you can just say, hey, do you have like a soda, like a Coke that could work? Do you have some candy? Do you have like any type of like garbage food that this patient can eat? Because even if we give them oral glucose, they're gonna need more solid foods, and that's usually as far as the call goes. A lot of times, once you bring them back a bit, uh, even if you give them like D10 or something, if they're like have an altered mental status, they'll usually say, "Hey, I don't want to go to the hospital. They're not going to do anything for me, and I'm perfectly fine now," and that's okay. Get them to sign the refusal, warn them about the possibilities that their sugar can get low, and make sure you watch them eat something like some type of carbohydrate before you leave them alone. But afterwards, you should be good. Hypothermia, I've never had it. And I'm glad I've never had it. I know some agencies probably deal with this a lot, and that sounds like a nightmare dealing with frostbite, but I have nothing to say about it. I just haven't dealt with it. Kidney stones, they're extremely easy, but I would treat these patients like they're my child. I feel really bad for them. These kind of calls, they're going to have a remarkable amount of pain. These are the type of calls where pain management should be one of the first things on your mind. I've never experienced a kidney stone, but I've heard horror stories about how painful it is. I mean, it's literally like a sharp, jagged rock going to the urethra from the what is it? The glomerulus, the kidney renal area, blah blah blah. I'm just making up terms. The kidney, going from the kidney to the urethra. It's extremely painful. Pain management is always on my mind. Electrocution. I've never had this before, but if I did, I would imagine that I'd set up a 12 lead. I look for an entrance and exit area if that is a possibility for this. I'd imagine it's going to be one of the upper or lower extremities that's going to have like kind of like an opening. But I can only speculate. I've never had to deal with this before, and I don't want to deal with this. If I have a patient and they're getting shocked and they're touching a power line, and my only option is to bare tackle them to get them away from the power line, I'm running for the breaker box. Sorry, I don't know you that well. I'm not going to risk getting electrocuted and dying also. I feel very bad for you. Uh, Also, a very funny thing that I learned in medical school is if you feel like, if you think that the ground is like, let's say if like you think that the ground has electricity going through it, let's say a power line fell and you think like, oh man, if I spread my legs and both are planted on the ground, I'm gonna get shocked. You can plant your feet next to each other and kind of bunny hop backwards away from where you think the electricity is at, and that should technically protect you because if you keep both legs separate, that creates an arc, and so the electricity will go like towards you or through you. That's what I've learned, but honestly, I'd probably just make a break for it. We actually almost had an electrical pole emergency pretty recently, but luckily it stopped right before it fell onto our ambulance, which is great. Uh, Not very good scene safety on our part, but oh well. MVCs, honestly, they're a little tricky if you're starting off. Um, but once you learn the correct things to say, they're fairly simple. I'll put them like right over here. You need to know the right questions to ask. So you need to ask like how fast were you going? Did you lose consciousness whenever you hit someone else or hit something? Were airbags deployed? Were you wearing your seatbelt? Are you on any blood thinners? Those are extremely important questions to ask, and if you don't ask those questions, you're gonna get chewed out at the ER. You need to know where the damaged area is at. You need to put a C collar on them. You need to put them on a backboard, or at least consider it. Ask where their pain is. Palpate the areas where they could have gotten injured. Look for a positive pulse-motor sensation to their upper lower extremities. Gather as much information as you can on the scene because once you leave, you're not going to be able to look back at this incident. But honestly, they're not that bad. Now, needle decompressions, I haven't had to deal with it, and I'm glad because it would go right here if I've had to deal with it. This seems extremely difficult, and I'm glad I don't have to deal with it. This is probably a once in a lifetime call. I don't want to deal with it, but if I do, if I will, or if I need to, I know you go between the second and third mid clavicular intercostal space, or you go between the fourth and the fifth rib on the lateral side or the lateral aspect underneath the armpit. I think you use four fingers underneath their armpit, and their fourth finger is where the fourth and fifth rib area should be at. But honestly, I need to do some more studying on my part. I need to do some training on it. But I don't want to deal with this if I don't have to. And luckily, I haven't had to yet. But if I do, I'm calling Kevin. I'm calling for help because this will be hard. But I will make the most out of it. Overdoses. Overdoses, I would say they're a little tricky. Um, a lot of people they associate opioid overdoses with elderly patients, but in all honesty, um, there are times where like elderly patients will have opioid overdoses. Sometimes an old patient will take like their hydrocodone because they have lower back pain, which is completely understandable. They're like, let's say 60 years old. Then 10, 15 minutes later, they forgot that they took their pain medication. They're like, I still have pain anyway. They take it. Now they're in the range where they could potentially have an opioid overdose. They drive to their, like, let's say, local church on Sunday, and then they go into a ditch. I've had it happen before, and it's just something you have to be vigilant for. But the uh, administering Narcan, naloxone, I mean, that's extremely easy. But it's just sad to see patients suffering from this. Be very careful. Consider Zofran for any nausea. You don't want them to erupt with vomit. I was on the paramedics Reddit page, and I think a person who was addicted to opioids talked about what it feels like whenever they get off of opioids from Narcan, and it feels like basically they go from like being in a relaxed state to being almost like exposed to like 500 degrees. Just the heat is unimaginable. They're in a whole lot of pain almost immediately because they're immediately getting cut off of the opioid receptor. So it explains why there's some like aggressive tendencies whenever you take them off of this. Now, electrical capture, I've never had to do pacing, but I'd imagine if I had to do it before, I mean, I'll get it done, but man, I have one of my coworkers I'd probably call Gabby while I'm dealing with something like this. But this is extremely difficult. I'd imagine. I just haven't dealt with it yet. PEA is annoying. So now if we're looking at, actually, I'll put this back here. We'll talk about PEA in a little bit, but it is annoying. A pediatric CPR call. This is going to make or break you. I had a pediatric CPR call, and I still think about it all the time These mannequin dummies that you practice CPR on, that's what a baby feels like when they're lifeless. It's a horrible feeling. I think about it all the time. And setting up a intubation, I don't think that people realize just how small a pediatrics airway really looks like and how ridiculously small it is. It's insane. Uh, Drilling in a kid for an IO is horrible. Looking for an IV on a kid is horrible. Everything about a pediatric CPR call is horrible, but once you do it, calls get generally easier because now you're not doing the pediatric CPR call. This is horrible to deal with, but if you get a save, it's got to be like the best feeling in the world. I have not had a save on a pediatric CPR call, but these are horrifying, and it's something that we have to deal with in our business. It's what we train for, but sometimes I feel like we just don't train enough for this. And how can you train enough for this, right? It's horrible. That being said, adult CPR calls, that's my bread and butter. That is my bread and butter. I can run these things in my sleep. Maybe I should put a little tricky. Uh, I mean, I do a pretty decent job on CPR calls. Now that's not saying I don't make my mistakes. Sometimes I don't hit my tubes right, my ET tubes, and we have to use like a supraglottic airway, like an LMA or something. Sometimes setting up an IV is really hard, so you go for an IO either on the humeral head or the right or the medial aspect of the tibial tuberosity, proximal, of course, to compared to the distal region, I guess, underneath the patella. But anyway, these, this is why you sign up for EMS usually, right? Like we sign up for it so that we can use our skills and so we can try to save patients' lives. And so a big part of this is cardiac arrest. So you should know how to run cardiac arrest. You should know how to do CPR properly, how to bag valve mask a patient, how to give the correct medications. You should know your dosages like inside and out. They're not difficult doses. And as long as your crew's competent, these are calls that we don't look forward to them, but this is our job, is to do cardiac arrest calls. These should be fairly easy. Now, your first one, it's gonna be hard, but once you become like pretty decent at them, these are calls that we just get to work, right? And we want to think like if we don't have enough room, if our patient's cramped up, let's say they're usually in the restroom and it's a tight area in the restroom, or they're on their bed and they had a cardiac arrest. Okay, well, what we need to do is we need the very first thing, life over limb, grab them and drag them out to an open area and get to work. Start with compressions and work from there. These are fairly easy to do. Just we have like little algorithm sheets. Just follow your algorithms. Be confident in your judgment. Do not forget to to check a blood sugar, because if you do, I don't care how good your call was. I don't even care if you saved them. If you didn't check for a blood sugar, you are going to be looked at with hatred, and they might just talk to your medical director whenever you bring them to the hospital, of course. Understand you're not a religious figure. Like, you're not Jesus. You're not going to touch a patient and bring him back to life, and that's okay. That's just something that comes with the job, and some of these might hit you pretty hard, but hopefully you can just treat it as a learning moment. But I've been very blessed. I have a very supportive crew. With both places that I've worked at, I have a very supportive department currently that will talk to me, and I can tell them my mistakes. I can tell them where I improved, and so for me, I feel like they nurtured me in an environment where I'm able to grow. So I'm lucky, but you might not be lucky, and that's a shame. But I don't look forward to a CPR call, but if I get it, I hope I'm lead so I can run it and do things properly. Preeclampsia and eclampsia, for a lot of people, this is probably a call for help, because it can be tricky as far as for like the agency that I work at or the department that I work at. For these kind of calls, we need to set up our mag sulfate. And the issue with our mag sulfate is we currently carry it at a 50% concentration. Now, of course, look at your agency or your department, see how they carry this drug or for mag sulfate, right? Because we want to administer mag sulfate for this kind of patient. For preeclampsia, as far as my protocols are, yours are probably different. Preeclampsia is 2 grams of the medication. For eclampsia, it's 4 grams. And you just think of like before the seizure and during or after the seizure. For these patients, we have to basically dilute our medication. So ours is 5 milligrams in 10 mLs. All we have to do is convert it to 5 milligrams in 50 mLs of a solution. The other 40 cc's is going to be saline, and that goes from 50% to 10% concentration. Then I can work with it, right? And each milligram is going to be 10 milliliters. It's not difficult conceptually, but I'm sure if you have a seizing pregnant woman and you need to administer 4 grams of mag sulfate, it's probably pretty difficult. I just haven't experienced it. Pregnancy, childbirth, I haven't dealt with it. I'm sure it'd be right here. I do frequently check OB training where I prepare myself for possible like pregnancy emergencies just because I haven't experienced it yet. And until I do, I just need to make sure my training's up to date. This is something that's like career defining. I'm extremely jealous of people that have been able to have an actual field birth. Of course, if I think that the patient is going to give birth really soon, I'm going to, as carefully as possible, head straight over to the nearest appropriate facility, like the nearest appropriate hospital. Let the professionals do it, of course, because we want the best survival chance for the kid in case there's a pregnancy emergency. But there's not much I can say about it just because I haven't experienced it yet. But I look forward to the point in my career where I'm able to help successfully deliver a child. And we shoot for gold. We always want to successfully deliver, but if it's not possible in the field or if some type of emergency happens, of course, deal with it accordingly. Seizures, I lock in. I lock in whenever it comes to seizures. I'm usually one who goes towards Versed first, just because you could administer it intramuscularly. Valium or diazepam is water soluble, so you need to set up an IV generally because it works better with that medication. However, I have had it before where I've set up IVs and I've given diazepam before, no big deal, but Versed is just such an easy drug to utilize. These kind of drugs or these kind of patients, you want to figure out like how long they've been seizing for. Are they epileptic? Have they seized a bunch of times? If they have, or have they seized in the past? If they have, okay, maybe family member come with me, so and so forth. You have to watch out a lot because you'll deal with like febrile seizures, and so you have to think, okay, they seized for 3 seconds. Why did this happen, right? Okay, it's a baby. They were probably in their clothes and they were laying down in like let's say a car seat and it was really hot. We might have to take those clothes off, put cold packs on them, set up an IV if you can. It's really hard for kids because we don't get many of them. And administer some saline, try to cool them down the best you can. We want a kid crying, right? We don't want a kid that's looking at his blank face because that's a scary thing. But seizures, we lock in, but I mean, honestly, I kind of want to put them in a little tricky, but you can deal with them. But we do have to administer a narcotic. Gunshot patients, they're easy. I mean, I can put a little tricky, but really, I can do these. I'm lucky. I haven't had one where they got shot in the chest through the lungs. If you had, it's going to go all the way down here. For me personally, I've never really had it. I've had it where they usually get shot in the legs or the arms. You can try to put on a compression. I've had to put a tourniquet on a patient before, but I've only had good experiences. If there are multiple injury sites, we can consider like TXA or tranexamic acid, I think is what it's called, to help and speed up the clotting process. You look for an entrance wound, you look for an exit wound. A lot of times it might look pretty flashy, but if your patient's stable, if the bleeding's stable, then you're fine. Of course, it all is going to depend on how your experience was with a gunshot patient. If it was bad, it's probably here. If it was good, it's probably here. For me, mine were good. It's going to go here. Stroke patients, I sleep. They, I'll put them on a little tricky. Stroke patients are very easy if you do the proper things. If you do not do the proper things, they are extremely hard. But what I mean by that, if I have a patient that's laying down on the floor, right? And let's say they're laying down, they had a stroke, but it was a witness stroke. They didn't bang their head. They got carefully placed down, which happens more than you would think, or they like were able to help themselves down and they're having a stroke, right? So like let's say they're laying down on the floor. The first thing I want to do, if I'm not worried about C-spine precautions, is I want to get vitals before we move the patient. So I tell my partner, get me a blood pressure. Please. I don't care really about anything else right now. Get me a blood pressure. Because I've had it before a couple of times where I've taken a stroke patient who ends up being hypotensive as well. And we get them from the floor to the stretcher. That movement alone probably drops their blood pressure about 20 units or 20 millimeters per mercury. And that alone can take a hypotensive patient to become like unreadable on the monitor. We can't even really get a reading manually, and it just becomes a disaster. And then this call gets insanely difficult. Get your blood pressures before you move these patients. Okay? Then it's super easy. At the same time, while you're setting up for the patient, if you need to consider C-spine precautions, backboard, do all that. What I like to do is, if I trust my partner, is I'll say, hey, get me vital signs, work with the brush company or the engine company, get vital signs, and then after you get vital signs, I can deal with the rest. Get them set up on the stretcher. If we need to set up a C-collar backboard, I'll direct them to do that. If I don't find it necessary, then okay. But get them on the stretcher then, move them into my medic unit. We'll go from there. While that's going on, I'm talking to the family member, right? Usually there's a bystander family member. How do they call 911? That's usually the reason or the way that they're able to. So I'll talk to them and I'll say, hey, how is it? When was the patient last seen normal? You need that information. If you don't get it, the nurses are going to chew you out, and the doctor is too, and you should be chewed out because you messed up. You did this patient a huge disservice. Oh, they were last seen an hour ago. Great, that's good information. Okay, what are they like normally? Do they normally walk and talk just fine? Yeah, they're good. Okay, what do you mean by good? Can they walk fine? They need a walker. Okay, that's not what I need. I need to know that. How do they talk? They talk fine. Okay, what's their normal? Uh, yeah, they're good. Okay, do they talk in complete sentences? No, they kind of just say yes or no. Okay, tell me that then, right? You need to really define what is their normal and don't just take base value. Yeah, they're good. No, I need to know, can they talk in complete sentences, things like that. Also, what saved me a lot on these kind of patients is I'll say, what's your name? Let's say my name's Miranda. Okay, Miranda, what's your phone number? And I'm getting the family member's phone number. Okay, I've got their phone number. All right, are you gonna go with us to the hospital? Are you gonna meet us there? I'll meet you there. I just need to close up the house. Okay, we'll see you there. We're going code 3, and these should always be your easiest code 3 calls. We're going code 3 with our stroke patient to the hospital. Uh, and at the same time, let's say if I forgot to ask a very obvious question, like, oh, do they have dementia, Alzheimer's, blah, blah, do they have a DNR, blah, 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 blah. Whatever it is, I can call back the family member and say, hey, I'm medic 70, so forth. I need to know, what is a patient like whenever they're normal? Because I forgot to ask that. But because I got the patient's family's phone number, I'm able to save myself there from looking like a complete idiot. Make sure you get a blood sugar on these patients. If you don't, you're an idiot. You deserve to get in trouble. Uh, but hopefully not in that much trouble. Hopefully you learn. But get a blood sugar on them. These are the easiest code 3 calls ever. Surgical crike, I haven't dealt with it before. If I had, I'd be right over here. But I haven't had to deal with it. I'm glad I haven't had to. I've had protocols where I've had this before at a different place that I don't work at currently. And I'm glad I haven't had to do this. Honestly, if I have a patient who I think that their airway is closing up, and I'm like, oh man, they're gonna knock out any second. I'm personally considering just pushing epi 0.3 milligrams intramuscularly. That might not be a popular opinion, but if I'm considering a swelling airway, I've had it before where a guy has horrible asthma. This was like a long time ago, and he has horrible asthma, and they were fighting a fire, and near their house, and they seem like they have an asthma attack afterwards. Okay, give them albuterol. Setting up an IV, blah blah. I have that set up. I want to take them to the hospital, and they're like, "No, I don't want to go." I'm like, you probably should go." And they're like, "Okay, I'll go." And as I turn around, I have like a student with me, and I hear the student say, "Uh oh." I look back. The patient is like semi-conscious, like gasping for air. Like they just sound horrible. Like their airway's about to close. They're like bobbing up and down. They have an altered mental status out of nowhere from being A no times 4, responding well to my albuterol treatment. Their lungs sounded clear afterwards. And I look, and my dang IV I set up is pulled out by the student. I tell him, "Hey, grab onto that, hold on, and stop them from bleeding. Dispose of the sharp, blah blah." Or not dispose of the sharp because it's just a catheter. Meanwhile, I'm just like, what do I do? This is technically their airway is closing because they're exposed to superheated gases. This really isn't like anaphylaxis or something. I'm just gonna pull out epi 0.3 milligrams IM. I push that drug, save the guy. He had jittery teeth, but went back to normal in like 2 to 3 minutes. Very clutch. Um, we're gonna put that here, by the way. So always kind of keep that in your back pocket. If their airways closing, talk to your medical director. Talk about your protocols. Get opinion from whoever's in charge of that. But IM Epi saved me, and it's a super easy save. SVT. It's kind of like they can be pretty difficult. You're going to administer adenosine. Depending on where you work out, you'll either start with 6 or 12 milligrams. So like for me, like I'll do 6 milligrams, then I'll wait 2 to 3 minutes, then I'll consider another 12 milligrams, then another 2 to 3 minutes, then another 12 milligrams, maxing out at 30 milligrams. I can consider synchronized cardioversion, but I don't want to really do that unless I have to, unless they're very symptomatic, like they have an altered mental status, hypotension, things like that. These calls, I'm kind of on the fence. I can deal with it. I've dealt with it before. I don't like dealing with this because in the back of my head, it's like, do I do synchronized cardioversion? No, they're not symptomatic. Okay. They're not too bad of a shape. I can still treat this medically. They're not like hypotensive and have an altered mental status, but man, they are not looking good. And so I'm kind of, if it's right here, it's very close to right here. But I'll put it right here. Syncopal episode. These are hard. This comes with competency. So if you have a patient, and let's say if I've had a patient before where they were handcuffed, and the guy's like drunk, he's squeezing at his handcuffs, and he keeps squeezing at his handcuffs, and eventually he's squeezing, straining, trying to bust himself out, and he vagals himself out from stressing so hard on his neck. He vagals himself out, passes out, and out of nowhere, I was a student at the time, and the guy like didn't have a pulse, and I was looking at the guy who's leading, and I was like, okay. I mean, we literally just saw this happen, and we were like, I guess we should start CPR, and then like 5-10 seconds later, as we're like getting the monitor ready and everything, we're gonna put pads on him to check out what the rhythm is before we start CPR because it was so bizarre. He got a pulse back, and then he just went back to being semi dazed to being an aggressive jerk again. So these can be very hard. I've had it before where I've given intramuscular injection to somebody. They passed out. They literally went into like a syncopal episode. But I steadied my nerves. I watched my patient, waited 10-20 seconds, and they went back to being able to talk, or they went back to a dazed state slowly as the body resets. These can be very tricky, and experience will help you a lot with syncopal episodes. So either go here, here, or here. Tourniquets, honestly, they're not that tricky to use. They can be difficult depending on who's like determining whether we should use them or not, or how we should use them. Um, but basically, I'm a big fan of compressing injury sites. Like if they're bleeding pretty badly, I think that if I have, let's say, an engine company with me or a brush truck with me, hey, grab onto that area with put some gauze in your hand, grab onto the area and hold on really tight. And if I need to take that person all the way to the trauma facility 20 minutes away, if the bleeding's controlled that way, guess what? Your new task is holding on to this wound till we get to the hospital. And I'll do that if I think it's necessary. Applying a tourniquet to somebody, it sounds great. I've been in a tactical a TCCC class before. If you put on a tourniquet properly, they should no longer care about the injured site where it's bleeding from. They should care more about this tourniquet and how they're going to trick you into taking this off or loosening it. Because a properly applied tourniquet hurts like hell. So I'm not a big fan of using tourniquets, and you can't even use them for somebody like, let's say, if it's a dialysis shunt that's opened up. At least as far as my work goes, you don't want to put a tourniquet on these. You just want to put direct compression. And if you think about it, dialysis centers don't use tourniquets; they just use direct pressure, which is understated in the books. They always say just go to a tourniquet if like direct pressure doesn't work, but like direct pressure works a lot of the times, or just plugging the wound depending on where it's at. So I'm not too big of a fan of the idea of tourniquets unless they're absolutely necessary. I've used them on calls a couple of times. They work, but I'm not a big fan of them. VFib, uh, it's pretty easy, and it's kind of like a good thing to see. We want to see VFib because it's like it's a shockable rhythm. They honestly have a better chance. We can potentially convert that rhythm into like a sinus rhythm or some type of rhythm that is better than VFib. It's pretty easy to deal with. Um, I mean, it's just going to depend on like your competency on working on a code. Do you know what drugs you need to use? Do you know your antidysrhythmics just in case? What are we going to do? PEA, that's a fucker rhythm. I hate this rhythm. It is a demon rhythm. I mean, it's easy to work with in some sense, but it's very frustrating to deal with just because you have to like you're thinking like, oh man, I went from like VFib to now I have a pulse. All right, let's do a pulse check. Oh, I'm not feeling. You check a radio and carotid pulse at the same time. I'm not feeling a pulse. How about you, partner? How about you, other person? Nope, no pulse. Nope, no pulse. Okay, well, I see a sinus rhythm on here, but if we don't see a pulse, uh, okay, 10 seconds have passed. Let's just start CPR again. And we can't shock this rhythm. It's very annoying, but that's why we do a pulse check. And even if we see something change, like a good change on the monitor, we do a pulse check. A lot of newer medics, they're going to see this and they're going to like be really hesitant for a while. What's the harm in doing CPR? If you don't see anything in like 5 to 10 seconds, if they have like a heart rate at 30 beats per minute, but it's like you determine that it's PEA, just go ahead and start CPR again. Another 2 minutes of CPR is not going to kill them any more than they're being killed, than they're already dead. Don't feel bad about starting CPR again. And then after 2 minutes, if you do another rhythm check, if you start to see that they're perfusing better, if you start to see like they're starting to have a pulse, okay, great. Like if you can feel it mechanically. VTAC, I mean, it's tombstones, it's shockable rhythm, but that's only if it's VTAC without a pulse. If it's VTAC with a pulse, oh, that's tough. That's very tough. But if it's VTAC with a, all right. So I should have made two of these. If it's VTAC without a pulse, easiest thing ever. If it's VTAC with a pulse, okay, now you have a problem, right? Like now we need to fix this quickly with medication or sometimes like a synchronized cardioversion. It just depends on how you want to treat this, depending on your patient's presentation. But if it's VTAC with a pulse, then or VTech without a pulse, I mean, I would put it almost like right next to VFib. But just because VTAC can be with a pulse or without a pulse, I'm going to go ahead and put it in call for help because I'm in trouble. Honestly, I need to brush up more so on like my medication dosages and how to deal with this because this can be pretty tricky if they have a pulse. But with that being said, asystole, honestly, extremely easy. I would put it like right here. We just work our algorithm, and we're just going to work with like our chest compressions. We're going to push epinephrine. If it's a long downtime, we're going to consider like sodium bicarb, something like that. Uh, for all these cardiac arrest patients, by the way, if they are a dialysis patient and you need to administer calcium, please administer that quickly. If you don't, you're going to get a lot of dirty looks from ER staff members, and you deserve to be look like that. You can run a perfect call, but if you don't administer calcium, then that's what you get. Kind of, right? I feel bad, but it is what it is. Uh, the last one here is, I can't even say this name because I think YouTube does not like this name at all. But if you have a patient like this, usually you'll have like some type of warrant from like a PD officer. Talk to them, try to be the change for them. Tell them like how important their life is. Try to get more on a personal level, because you're going to be one on one with them in the box, and maybe you can be the reason why they look forward to life, right? This is extreme. I mean, you do have to lock in for these kind of calls, because you have to be their friend and you have to work with them. Hospital staff, they have like a lot of hospitals that I've seen, they have a really interesting approach to this, because they have to support the patient, and like psych eval patient places will definitely do a better job on that. But you can't be too nice to these patients, because they might determine that, oh, it's a way to, like, at least I don't personally do this, but I've seen this tactic used before. If you're too nice to them at the hospital, and this is the only place where they get treated nice, they might do these things frequently, where they put themselves in harm's risk, where they potentially risk ruining their like liver, because they want that kindness from the staff. And so you have to almost teeter between being helpful to them, but also like discouraging this act. And I've seen it before where like you can't really, sometimes people aren't too kind to these people, at least hospital staff wise. I'm not saying that we do in the EMS wise, just because they don't want to encourage them to do it again. However, for the department that I work at, we're extremely kind to these kind of patients, and there's a lot of tactics to it, a lot of psychology to it that I can't really go into. But that being said, this is the list, everybody. I hope you enjoyed it. It was a lot of fun. Depending on how the comments go and everything, I might do more of these. I might not. I kind of want to go one into like medications. But let me know if you had completely different experiences. Cardiac arrest for you, maybe they're at the worst for you, maybe they're at the best. I wonder why. Maybe some like self reflection for me, like why were these at the bottom for me, right? Why weren't these at the top for me? So I could always do better. But with that being said, I hope you guys enjoy the video, and I'll see you on the next one.